welcome back to the Gillett Health podcast. We have a special episode today, and we have two guests, Ben Baros, a pharmacist that consults with Gillett Health, and also Alec McCarthy, PhD in regenerative medicine, that wrote the article Emerging Roles for Medical Affairs in Telemedicine. So the first topic today is the dark side of science, how you can find things that both clinicians and scientists can help prevent. So we're starting with the story.
Story time. This is a story about the Demon core, which is a plutonium core. This is back in the 1940s when they were conducting some essentially early nuclear research. So a scientist by the name of Daglian was stacking tungsten bricks around this core, and each brick that he added to this brick enclosure was bringing the core closer to critical mass. While attempting to stack another brick around the assembly, Daglian accidentally dropped it onto the core and thereby caused the core to go well into supercriticality, a self-sustaining critical chain reaction. He quickly moved the brick off the assembly but received a fatal dose of radiation. He died 25 days later. So, hindsight is 2020. We would now look back and say, why on earth would you be stacking these reflective bricks around a plutonium core? Because we understand more about the consequences. But one of those areas, the dark side of science. Interestingly, this isn't the only accident that this core was involved in. I believe there was a second incident before it was melted down and repurposed.
That's pretty scary. In healthcare, we have this Swiss cheese model where there's multiple stops. So the medical assistant is looking for a stop, perhaps the MSL is looking for a stop as well, and then the healthcare provider is sort of the rind in the Swiss cheese model of healthcare. It's definitely scary to be working with something that can literally kill you, like radiation poisoning. But it's also scary to be working with patients where you can literally kill them as well.
Yeah, I think when I was working in the hospital, it's a great example of how essentially all of us would be functioning within that model. You have the scientists who are doing the research, testing the safety, testing these treatments. You have the physicians that are ordering these treatments for patients. You have the pharmacists that are verifying there's no drug interactions, and then you have myself, an RN at the time, who is scanning things into the electronic health record, yet another layer, making sure that there's no interactions there, no contraindications with the patient's current clinical condition. So to have a bad outcome, really so many things have to go wrong, and it's much better that way. More layers of safety.
You know what, it makes me think of a lot of testing that was done and a lot of studies in anabolic steroids with drugs like fluoxymesterone in the 60s, 50s, 60s, 70s, that now we would definitely not use those drugs, but back then they were used and trialed for recovery and anabolism. And that was very interesting because now we know better about how they are harsh on the liver, all the 17AA anabolic steroids. And we would see that now thinking, oh my God, there's layers of safety that must be implemented before giving someone 50 milligrams of Halo, right? So that's just some of the things that we've seen, I think even recently with the ban on the over-the-counter Superdrol, right? Or Epistane, or all those drugs that we're familiar with now. And we were thinking, but didn't it that cause a lot of liver issue, a lot of liver damage, and you go to the local GNC and you get something that is really harsh on your liver. How does that happen? And I think now we have obviously much more experience, so we are more cautious. It's not as fun. You don't really see studies on fluoxymesterone or whatever, DMZ or whatever, but you don't cause as much damage.
It raises an interesting question of how do you arrive to these conclusions, and the logical approach has generally been animal models,
right?
And we have talked about in the past the low clinical translation rates with using smaller animal models. For example, a murine and rat models have approximately a 2% clinical translation rate. So it's always interesting to see which bodies of researchers and clinicians either support or oppose using animal models to elucidate some of these drug interactions and carry out these studies. So then the logical question is, if not on humans, what is suitable? Is in vitro studies sufficient? As computational chemistry gets better, people are starting to use a lot more computational drug-ligand, drug-drug interactions. So I'm curious what you guys think about this.
Maybe you can clarify a bit, but intuitively I would think, okay, you have a promising preclinical finding maybe in a mouse model. So you think, okay, we'll see, does this translate to human tissue in vitro? So if you have positive findings there, then you say, okay, what about human tissue in a living organism? So you have human cell lines in a mouse model. And then that's when you would progress either upward to human trials, depending on the safety, or to larger mammalian models. But I'm sure you understand the process much better than me. I'm just speculating there.
Yeah, that's generally the order of operations. And it's interesting to see which animal models are preferred. In other countries, you often see canine models used, horse models used, but in the U.S. generally, I think, at least in my experience, we strove to hit pig models, porcine models. So it's, it also, back to the dark side of science, brings up, in the past, we learned a lot doing ape experiments and monkey experiments. And for example, Morgan Island off the coast of South Carolina now has a population of 3,500 rhesus monkeys, of which approximately 600 are harvested for studies each year by the NIH and NIAID. So there's always there's pretty consistent pushback on doing that, but at the end of the day, if we're not using high fidelity animal models for these tests, humans are really the last experiment, and so there's a lot of unanswered questions if you remove that animal model to begin with.
It seems like as you go up in size, like nobody has problems with experimenting on fruit flies or nematodes. Some people are like, oh, well, the mice, maybe that's a line that some people are not comfortable with crossing. They say, no way. Go to a canine model, people will say, absolutely, no way, can't do that. Go to a primate model, people are like, no, that's too sophisticated of an organism, no way. But then you eliminate all those, you're really escalating the potential harm each time. If you go right to testing on humans, very bad things could happen.
Exactly.
It depends on the potential benefit as well. So are you running a trial on an animal that is purely to see what happens or for toxicity or whatnot? Or are you running a trial that could potentially be therapeutic as well? For example, in the dog aging project, they give dogs that are prone to certain types of genetically linked cancers due to genetic bottlenecking during the world wars. And they give them a drug that's rapamycin, mTOR inhibitor. And it certainly has the potential to help. We know that in mouse models it helps, and it's well tolerated even in human studies. So a project like that, a lot of individuals who are against other forms of canine clinical trials would be okay with that.
Yeah, giving the potential for your man's best friend, your pets, your loved ones to live longer, healthier lives.
Yeah.
So you have to look at the potential benefit, and in general, I don't know the results of that trial haven't been released yet, but I would suspect there would be a low incidence of adverse outcomes, and at worst a neutral effect, and at best a positive effect based on they're really the stepping stones that have been studied on the other clinical models, preclinical models.
Yeah. Speaking specifically about dogs, it's also interesting to see what outside of clinical trials culture or society is willing to accept. For example, they're willing to accept neutering or removing the testes of dogs. That's no big deal at all. There is some studies on vasectomies for dogs to maintain their quality of life and decrease the incidence of fractures later in life, so on and so forth, and sarcopenia. But that's totally fine. But then if you do a clinical trial that has a well-tolerated pharmaceutical potential and then relatively low incidence of side effects and the potential for benefit for both canines and humans, then that becomes not okay.
Agreed. It's a very complex landscape to navigate as a researcher. There's a lot of negotiation with IACUC boards and conversations with IRB boards. What is the most suitable? Obviously, there are a lot of regulatory bodies that you also have to weigh, which makes it an extremely complex. It's funny, people often wonder, how is it possible that an IND, an investigational new drug or device, has a 10+ year pipeline, timeline to the market space? This is a great drug. It could help a lot of people. Look how great this preclinical in vitro data is, and then you embark on an extremely long journey. And this is one of the reasons why is it's an extremely complex landscape that you have to figure out what's the appropriate number of animals to use, which one is has the least harm and causes the least harm with the highest benefit, which gene expression profiles for this specific organ or disease state looks like it will translate with the highest fidelity. So it is an extremely complex equation.
Because you go from computer to in vitro, and then you go to animal, and you have to find the right animal model, and potentially something that would translate well to humans, and then you finally upgrade to the target population, just a really small, high risk, potentially high reward human population, so a very small group. And then you have phase 2 trial and whatnot, just expand slowly with more candidates, and then finally you can potentially get the approval from the FDA, and that's when you publish champagne, obviously. But it's a really, really long process where you start from a petri dish to whatever animal to a small population of humans, and hope that everything goes well. And finally you can expand it. It takes a long time and a lot of money.
It's interesting to see cases of when the efficacy of a certain new drug supersedes the timing. For example, with insulin, I believe they went from doing trials, I forget if it was pigs or sheep, maybe sheep, but they were doing a trial with sheep, and they were saving the lives of these sheep or pigs with induced type 1 diabetes, like pancreatic death. And I think it was 3 months later, they were already injecting a ton of different kids with insulin.
For a potential life-saving treatment.
Yes.
As Ben talked, such a long and expensive process. I think it's interesting to look at the opposite way, the opposite timeline. So you have drugs that are already out on the market, they've been approved for a long time, and then they find out they have additional mechanisms or additional actions in the body, and they can repurpose those things. And a lot of this is precision medicine, where they can look at, oh, you have this particular type of cancer that's known to respond to this. So things like the rapamycin or rapalogs. You've seen some case studies where there are, renal cell carcinomas with a very high 5-year mortality rate. People are like in complete remission for up to 7 years. So they're essentially a hyper responder because of the receptors that this particular cancer, whenever they go look at the pathology, is expressing. So it's just about finding the perfect piece to plug in there, and that's really interesting. Another one, Simvastatin, for example, something that I would tend to not prescribe because it has more lipophilicity. It's going to accumulate in peripheral tissues and tend to cause more side effects. But in the case of like a glioblastoma, when you want tissue penetration into the brain, for example, that could be a useful vector. Certainly not a cure, but it's something that they are looking into because statins have been associated with some anti-cancer properties, and that one in particular has a high degree of penetration into the brain.
it's been interesting too from the academic side to see the emergence of precision medicine research and big data. So, I think eventually there will be significantly less small animal models used because that can be, easily replaced by computer modeling. And to the same, to your point, there are entire PhD programs based on drug repurposing, and all of that is just big data, and it's an extremely interesting field that I think will probably have a significant impact on both research and clinical practice way sooner than a lot of people realize.
It's always interesting to know that a lot of drugs, they hit the market because it's not something that was planned. We can talk about Viagra, sildenafil, obviously a pretty well-known medication for erectile dysfunction. That was not the original purpose, right? That was blood pressure, and so we find so many things. I believe that finasteride for hair loss is also someone found out that there was a benefit for hair regrowth or stalling hair loss as opposed to prostate benefit. I mean, there's still prostate benefits, obviously, but it got marketed as a hair loss medication at a lower dose, and that just happens so often. So repurposing is something that is common based on real life observations that may be actually not even intended, right? It's just you get lucky.
As providers, is that something that you look for when you are deciding what treatment modalities to use? Are you looking for compounds with multiple therapeutics or therapeutic benefits?
Absolutely. It's really common that we pick, for example, with diabetes medications, you pick one that has another benefit. For example, you pick one that has a weight negative effect to help with body recomposition and weight loss, perhaps prevent bariatric surgery. Even with, for example, let's say topiramate, you're also looking for, you might have a benefit of mood stabilization, but a detriment of kidney stones. So if you have a history of kidney stones, you're not near as good of a candidate. So you're certainly looking for secondary benefits. Perhaps someone has a bit of adult ADHD and they do better on Contrave or something with bupropion in it. So you're certainly looking for other indications. I think one thing that we run into quite often is the patient is actually looking for other indications. For example, perhaps a patient comes with us and they have a borderline hypertension and they're asking us about, they actually do quite often, a low dose of telmisartan, because it's not only an angiotensin receptor blocker or an ARB for blood pressure, it's also a very weak PPAR delta agonist. And maybe they're a marathon runner and think that even that tiny bit of PPAR delta agonism has a fringe benefit.
That's really interesting because I think this is the patient population that you see combing through WADA's watch list every year. They're like, oh, what could possibly have a performance enhancing vector here? So you have people that say, oh, there's a little bit of PPAR delta agonism, and there are more potent PPAR delta agonists, which we've spoken a bit about. Cardarine is a research chemical that people are using that has significant cancer risk in preclinical models, so it was essentially scrapped altogether as far as delving into that for cardiometabolic benefit. But looking at long-term, thinking if somebody is an athlete, they're trying to push the limits, they're in their 30s and they say, oh, I'm going to take this telmisartan. Well, then maybe they do go on to develop hypertension. Do you want them to have 60 years of low-dose PPAR delta agonism, or whenever your immune function starts to decline and your tumor suppressor genes are mutated, when you get into your, let's say, 60s, just ballpark, would you switch over to a medication that does not agonize PPAR delta? And that's where the nuance gets really fun and really interesting for myself.
Definitely agree. It's a moving target across a lifespan, and often when you're thinking about true preventative medicine, you're finding something that has efficacy, but it is often not very strong or a high dose. Statins are a pretty good example of this for individuals with familial hypercholesterolemia. There's been studies, I believe there's one in Korea, looking at specifically ages 19 to 39. And then they looked at ASCVD, or heart attacks and strokes essentially, later on in life, in the group that did something for lipid control versus nothing. So doing a very small amount for a long period of time can be a better option than waiting until you have the end pathology. So you're doing, instead of primary prevention, it's secondary prevention, but then it's not really even prevention. It's just secondary prevention, you're just preventing recurrence. And often you require much stronger medications, much higher doses, and those have many more side effects.
Yeah, by the time you have a vascular event, you already have like atherosclerosis and substantial plaque buildup in the arteries. That is very hard to reverse. You can see some statistically significant reversals. Usually those are with high intensity statins, the addition of PCSK9 inhibitors, or even some very, very low fat plant-based diets, which a lot of people don't like to hear about.
So as a provider, what would be a low dose that you like someone who is in their 20s or 30s, seems to be at risk? How low do you like to start with something like rosuvastatin?
Often I start all the way down with rosuvastatin at 5 mg, sometimes even half of that, which is 2.5 mg.
Daily.
Often even less than daily. There's a study, KU, University of Kansas was one of the institutions, but several of these institutions looked at every other day or 3 times a week administration for statins. Each statin has a longer, shorter half-life. So rosuvastatin is almost a week, whereas some statins have a very short half-life. So depending on the situation, we like to look at the ApoA1 to ApoB ratio, and often a lipo profile to look at particle sizes as well. Oxidized LDL. So after you, for example, that's in the example, this person has familial hypercholesterolemia, or perhaps they just have a significant dyslipidemia. You want to look at more parameters rather than just an LDL. Yes.
The ApoA1 to ApoB ratio is a really good indicator. This is from old data, actually, the Innerhard trial. And what I found most striking about that is the highest quartile of ApoA1 to B ratio, people with the highest apolipoprotein B levels, actually had a higher hazard ratio than your average smoker. Now, you could certainly exceed that depending on the volume and the time of exposure to the cigarettes, the smoking. And probably the same is true. A good way to look at cholesterol is your time of exposure. So have you had an elevated apolipoprotein B since you were 18, or did you just develop this in your 40s when you started to have metabolic dysfunction secondary to something like insulin resistance or obesity?
Absolutely. This is why you see a lot less lipidology clinics. They're changing over to cardiometabolic clinics instead of trying to separate the same field into 2 different halves of the same coin. It's just a cardiometabolic clinic.
It's really interesting to do all those testings with Gillett Health when we look at complete health and cardiac health. We look at everything, right? We just cannot prescribe a statin based on LDL-C and HDL anymore. We really want to look at the lipo profile. We want to look at particle size. There's a very interesting debate, obviously, about cholesterol where people will say, well, LDL is just, it doesn't matter, it doesn't really mean anything. And I'm always playing devil advocate. I'm saying, okay, well, it doesn't matter, but let's look at the lipo profile. And then it says your particle size is totally inflammatory or associated with inflammatory. And maybe your oxidized LDL is high and your small dense LDL is also high. So are we going to still say it doesn't matter, LDL doesn't matter? And you want to have the full picture. You cannot just guess based on LDL. I get it, but we definitely want to test for more. And that's pretty much what we do. And the ApoA1 over ApoB ratio is very important as well. I think that should be pretty standard before getting anyone on a statin. And it's very interesting when we look at the results. You can have, I mean, it's quite rare actually. You can have a pretty good LDL over HDL, the basic lipid panel looking good, and then for the rare people who say, well, I just want to test everything, and then you can have a good LDL and then oxidized LDL is through the roof. Seen that recently. So you want to work on obviously antioxidant slash oxidant ratio of you want to make sure someone is, why are they oxidizing that much? So, and what about the antioxidant? But it's interesting to see a lot of people saying, well, LDL doesn't matter, and now we test for more and everything is in the red. So when does something start to matter? So what would be the biggest test, or what not the biggest test, the most important test you want to look at beyond LDL? What would be you have oxidized, you have small dense, you have A1 over ApoB.
We get this question from clinicians and patients often, and the answer is you look at as many vectors as possible. So you're looking at your dyslipidemia vector, you're looking at your which includes ApoB, ApoA1, oxidized LDL, lipo profiles. You're also looking at your insulin resistance, or the other cardiometabolic vector. So you're looking at your HOMA-IR ratio, you're looking at your fasting insulin, you're looking at your CGM, then you're also looking at your inflammatory vector. For example, if you have psoriatic arthritis or rheumatoid arthritis, that in and of itself is a significant risk factor for ASCVD, which is the heart attacks and strokes, plaque in the arteries where you don't want them. So that's obviously inflammatory. Nicotine use is inflammatory, even just a high CRP. So if the individual has Crohn's and their CRP is high most of the time, perhaps they're myeloperoxidase, you want to check all of your different inflammatory markers and also your acute phase reactants. For example, platelets. If your estrogen runs higher, your platelets tend to run higher, and your SHBG tends to run higher as well. So all of those things, you look at them as one picture, and that's I think that is a huge positive of individualized medicine. So you're not just going by an algorithm. The algorithm says, LDL over 130, do an ASCVD 10-year risk. It's not going to give you you can look at a lifetime risk as well. But if an individual wants to live more than 10 years, they probably need to look at a risk past their 10-year risk.
Yeah, the 10-year risk is quite short-sighted. It's like if you're thinking about planning for retirement or filling up a savings account, it's like, well, I'm only going to have this much in 10 years. Why would I start investing now?
Yeah.
So if you look at your lifetime, like, oh, by the time I'm 60, 70, I'm going to have quite a good amount of savings. And you want to kind of think of that as your health reserves and being very proactive. And I think a checklist can be applied. So you're looking at, the ApoB or just your lipidology in general, even some genetic things like lipoprotein a. And then you're also going to look at any current disease states, and that's where it's very individualized. So, for example, regardless of what somebody's, lipids look like, if they're diabetic, they do stand to benefit in general from even a low dose of a statin. And I think the type 1 diabetes guidelines are particularly interesting because type 1 diabetics have such a high risk of vascular events and all kinds of sequelae from the disease process. But the guidelines currently seem to indicate, wait until they're 40 and then you start a statin. And for me, that seems more like a reactive approach than being proactive, because they didn't become, in most cases, type 1 diabetic at age 40, although we do see some later onset type 1 diabetes. And to your point about the autoimmune conditions, there's a bit of a autoimmune component to atherosclerosis. If you look at the T cell immune cells that get dysfunctional as people increase in age, they are going to tend to kick off that inflammatory cascade to try and remove the cholesterol from that subendothelial space and cause damage in doing so. And looking at things that are immunomodulatory, there was I believe an interleukin 10 inhibitor that showed mild benefit in patients with the highest level of C-reactive protein. And this was on top of the standard therapy. So you don't pull somebody off of a current therapy that we know works to test out a new therapy. It's typically an adjunct, which is why the PCSK9s are so impressive, and the interleukin 10, I believe it was not all that impressive. But I would be interested to see that deployed in patients with autoimmune dysregulation, because then they're going to be in that high, assuming they have more periods of inflammation, they're going to be in that high CRP category, so they may be a subset of patients that stands to benefit much more from that therapy.
that is particularly interesting both for autoimmune pathologies and also for infectious pathologies. So just a hyperactive immune system after an infection. Quite interesting. One other thing that people often ask about is if you look at the expert opinion, so again, it goes back to your pyramid of levels of evidence where your systematic reviews, meta-analyses, randomized controlled trials, cohort studies, case control studies, and then expert opinion. The whatever is covered, and we get this question literally all the time, whatever is covered is not necessarily based upon the highest level of evidence. So there could be excellent randomized controlled trials or even systematic reviews, or even a Cochrane review that says, yes, this is helpful in this category, but it is not covered. For example, we no longer, very few insurance companies want to cover laboratory monitoring for creatine kinase for those on statins. So a proxy of muscle breakdown, which also is going to be higher if you exercise often. And also many do not routinely recommend checking a CoQ10, which is an enzyme that can be depleted during statin therapy. Yet for the individual who wants to have as much benefit with a minimally efficacious dose, those two things are arguably very helpful.
Yeah, the CoQ10 depletion and creatine kinase levels could be your dose-limiting findings for a statin. You push up the dose of the medication to achieve a more therapeutic effect. Anytime you have an increase in dose, you tend to have an increase in the potential for side effects, and also depends on how quickly or how slowly people are metabolizing drugs, because we've all heard the anecdotes and case studies, and even now with the pharmacogenomic research coming out, that people don't respond to the same medications the same way. As much as that would make everyone's jobs much easier, it certainly makes it more interesting.
There's very interesting variations when it comes to metabolism of those medication. That could be in the liver or in the kidneys. We were looking at the glucuronidase differences in populations. So something like testosterone is actually excreted in the urine by most people. I mean, that's what we would think. And now we have case studies where we would inject 500 milligrams, and you have 40% of the patients that were tested, that were in that study, that were recruited, in whom you will not see testosterone in the urine. So it makes you think of what's going on when you're going to test for doping, and you actually have people who may take testosterone, and they know that it's not excreted in the urine because they have a different metabolism in terms of their genetics. So it's very interesting to look at differences in population for any drug. Obviously, I'm saying testosterone, but that could be any statin. That could be, I was reading about Tylenol, although Tylenol doesn't seem to have that variability, but it just depends on the drug, and that's really interesting to look at it. A lot of the research may be done mostly in Caucasian populations, but you would want to look at Asians, Africans. So you kind of, because there's going to be a interracial difference in metabolism of drugs, which is really interesting to look at.
Yeah, I think that's one of the reasons why they came up with the biologic passport system, where they track an individual over a long period of time. They can track ratios of testosterone to epitestosterone. And then also, from the clinical side, it's a great indicator that precision genomics can make a big difference. So you have insurance cover things like Genomine or testing for single nucleotide polymorphisms for oncology. But those are able to be checked for pretty much any drug. It's just a matter of, do you have that data, and is there somebody that is a clinician rather than a scientist that is willing to go comb through that data and find its clinical applicability?
So as a patient, how do you make sure that you have access to this level of individualized care? Because it sounds like you really need, to have a clinician who is extremely familiar with navigating these types of databases and tuning this, to this degree of personalized medicine. How does a patient guarantee that this happens? Or what can they do to make sure that, they're seeing a clinician that has these resources?
The analogy that I like to make when you're finding a clinician is when you're looking for an answer, whether it's an answer about health optimization, you're trying to have optimal athletic or cognitive performance, or just a very long health span, that is a relatively difficult question. Or if you think you may have a zebra, which is what we refer to as like rare diagnoses, that's also a difficult question. If you have a difficult question and you're in a class, you don't just ask the teacher. So you don't just ask the society that makes the guidelines or like look online for that. You don't just ask who you think the smartest kid he or she is in class. You would ask everyone and look everywhere for the answers, and you would look and see what other people have found that have had similar questions. And that's probably why a lot of people listen to podcasts like these.
Right.
And then you would shop around. So just like, if you had let's say you have a race car and you're trying to have perfect performance or find something that you think is wrong with it, you would likely go to several different mechanics and see what their opinion is, and then choose them over a long period of time for a period of many years, and then work with them in tandem over years, doing a process that we call shared decision making, which is we know your goals, whatever it is, and then we are willing to continue to dig. There is always more digging to be done, and I never like to say this is due to aging, and I also never like to say we've done everything that we're able to do, because there's always more digging.
Yeah, and finding a clinician that is going to take their time and dig into whatever your particular question is typically not going to be in the traditional medical model inside of insurance and organizational constraints. You're typically going to find that outside of that model. For example, all the time we'll have patients ask us questions like, I read about this supplement, or I saw this, this scientist that said that this will lower my blood pressure, or lower my cholesterol. And it's important to go and look at those studies with a nuanced eye, because is that, extra serving of blueberries lowers blood pressure? Is that by 2 millimeters of mercury, or is that by 20 millimeters of mercury? Because you can have, it's something we say all the time, a statistically significant difference, but it's not going to make a clinically significant difference. Same thing with cholesterol lowering supplements, or supplements that can move the HDL and LDL numbers around. Maybe it's a 5 or 10 point difference, but is that going to translate to treating somebody with familial hypercholesterolemia? Can I just take citrus bergamot instead of a PCSK9 inhibitor? No.
Yeah, and I think this is one of the reasons why interest, I think I saw a 5,000% increase in searches for functional medicine and integrative medicine, because people intuitively know that if they have a problem that is not one of the algorithmically solved problems within our current system, they seek healthcare outside. So there's a 5,000% increase in searching. But when you're looking at the intersection of conventional medicine and functional medicine, there is not a good standardized, there's like no Cochrane review, there's no up-to-date specifically for functional medicine.
Right. Also going back to the last point, it's something that we talked about yesterday. There's a ton of journals, there are a ton of publications, and you don't need to have a medical background, you don't need to have an MD or a PhD or a PharmD to sit down and gain meaningful insight from medical literature. But there is a caveat, which is how do you know which studies are good? How do you know which journals are reputable? And to a patient, what should they be looking for? And we could even take it one step back even further. How do they even access medical literature of the same quality that a healthcare provider could access?
That's a great question, and a lot of times there are journals that healthcare providers, unless your organization is subscribed to that journal or has some sort of partnership, those articles are typically going to be behind a paywall. So personally, I've reached out to some PIs or whoever the correspondent is for the article, and they're more than happy to send over a PDF most of the time to get you access to that information. But for your layperson, Should they be sending out emails to the authors? Should they be going to a public library perhaps that has some of these sorts of memberships? What would you say for the layperson who wants to get access to that research? And then talk about those things with a qualified provider. How would they actually get to the articles in the first place?
I think a really good place to start is Google Scholar or PubMed, where you can filter articles by open access. So open access or Creative Commons published articles, are free to read. They're not behind a paywall, and generally, they're easy for somebody to search, find, and download the PDF. And there are institutions like you mentioned where if you have an institutional login, you probably have access to a significant number of journals, but to the layperson that's not super helpful. I think that ResearchGate is also a really useful tool where it's free. It's a free platform. It's basically scientific and clinical Facebook, but most of the publications there, whether or not they're open access, you at least can make a specific request for a PDF of a paywalled article, for example. That being said, does it make a lot of sense for a provider or a patient to spend a tremendous amount of time reading all of the literature out there? Definitely not. So I guess I have my thoughts on sort of how to approach a literature review. What do you guys do, or how do you make sure that you're not wasting your time?
This is one of the things that you learn to adapt to in medical school as well. They have journal clubs, and you look at the article very critically and constructively at the same time. And you're looking at all parts of the article and what its limitations and benefits are. And you're looking at what the goal of the article is as well. So there's a couple different ways to approach it. If you're doing a peer review, then you write out that info and you try to be helpful. And then you take whatever knowledge you can away. And then if there's something in the conclusions, before you even read the conclusions, that you did not think was portrayed as well as it could be, then just keep that with a grain of salt. That's why we have the peer review process.
I think that starting with review articles is probably a really beneficial, or a beneficial starting point specifically for patients. You can definitely extract the most information in the least amount of time with a reputable review article. And it's easy to get lost in one of the 300 to 400 references cited in a review. So I always think that, at least during my PhD, if I was starting a new project or reading about a particular disease state, I would always start with multiple reviews before I would get into the weeds of the data.
Definitely, you go down that tier of evidence. So if you're looking for a specific question and not necessarily just evaluating the article, you want to start with systematic reviews or meta-analyses. And that's why some journals are more patient-friendly. For example, Cochrane Review or New England Journal, they have their pros and cons, of course, but they are quite patient-friendly when you compare it to most journals.
Right, agreed.
Yeah. And it's interesting, sometimes we'll have the case where a patient, they have an article because, basically if you're looking for something in the literature, you can find that either in vitro or preclinical. We joke, you go to iamright.com and here's your answer. But the patients will say, well, what do you think about this article? And you look at the sample size that was involved in the study. Is it 10 people or is it 10,000 people? You look at the differences in the control group versus the intervention group if it is a interventional trial. And there's just many things that you pick apart there. Sometimes you'll look at the subgroup analyses, which are showing a statistically significant difference, but it's not adequately powered. So subgroup analyses in general are more for hypothesis generating than applying to a clinical population. A great example of this is some of the aspirin trials way back when that was being investigated for treatment of acute MI. and they actually had a pretty difficult time showing benefit. But eventually one of these trials showed a strong favorable effect on acute MI and aspirin, but the initial submission actually got rejected. I believe this was the New England Journal of Medicine. I may be mistaken there, but it was a prestigious journal, and they said, hey, we want you to do a subgroup analysis. So the investigators of that study did their subgroup analyses by astrological sign, and they actually found 2 astrological signs that had no benefit from aspirin therapy. Now, that's certainly not evidence-based medicine, and it just shows the the more ways you slice and dice the data, the more likely you are to find something just by coincidence. It's hard to imagine a world where they go into an ER. What's your date of birth? Oh, nothing we can do for you.
Nope.
Sorry.
Yeah, it's really interesting leaving academic science and then going into medical affairs. So I work in dermatology, and you read literature that is a statistically significant difference in dermal thickness of let's say 70 nanometers. And is that clinically observable? Does that data matter to the providers and to the patients? Is it observable? Probably not. So it's always, and especially with in sort of this supplement and nutrition world we live in, where very, very marginal or statistically significant, but is it clinically relevant? It's always an interesting debate. What do you guys? How do you frame that for a patient? Maybe there is some benefit, but is it significant? Is this worth your time or money?
You have to see it through 2 different lenses, and it has to kind of pass the test. And the first test is what you see in the literature, the statistical significance, and that's not just p-values and odds ratios, but you're trying to find, every patient is an N of 1.
Yep.
So even if you're finding the most specific group with all confounding variables addressed, each patient is going to not perfectly align with any one study, but you try to apply it as well as you potentially can. And then you're also viewing it through the lens of your clinical experience. And I think this is one place where perhaps nurse practitioners and medical doctors, DOs and MDs, are somewhat different, since DOs and MDs are slightly more, they have a more scientific background, especially in the first couple years of medical school. And then they develop the experience later on. Whereas if you're from a nursing background, you develop that experience first, and then theoretically go on to develop the more scientific background.
Yeah, it's really an interesting comparison, because the initial nursing school, say somebody's going for an associate degree of nursing, they're going to go work in the ICU. You have to have a rudimentary understanding of the pathology behind what you are treating, what you're giving medications for, when not to give that medication. But it is very simple. And then you learn through your clinical experience, as opposed to in the setting of an MD, you are essentially stacking 4 years of, the background, the foundation of everything, and then building the clinical skills on top of that. Whereas the route to an NP is sort of a very small foundation of, anatomy, physiology, pathology, and then you have a varying window of clinical experience. I think the larger that window of clinical experience, the more valuable that is prior to embarking on a path to further your education. For example, going to get a master's or a doctorate in nursing practice. You want to have some experience so that you are getting a number of hours exposed to the patients, the pathology. The more time you spend around patients, the more things you're going to pick up on. And a lot of it is latent learning. You may not even realize it, but you are learning. And you get out of it what you put into it. You could see a new condition come across, like, oh, I've never heard of this before, probably never see it again. Or you could say, oh, this is a new condition I've never heard of, I'm going to look into this. Mm-hmm. So I strive to be a lifelong learner, and I had probably 6 years, if I'm thinking correctly, where I was a working RN full-time prior to becoming a nurse practitioner. So I feel like that time frame, and also the fact that I worked in a float pool. So I went to all these different units of the hospital. I wasn't just in the cardiology bucket, or just in the nephrology bucket, or just in orthopedics. I was able to get exposed to all that different pathology. I think that's really, expedited or cut my learning curve as far as like understanding about each different body system.
It's an interesting, or it's a nice segue into, how do our degrees differ? How are they similar? How long did they take? And, what do we do now? And where do we see others with our degrees working in and outside of healthcare?
And we can even add a layer of complexity, because I was going to pharmacy university in France, and I don't want to speak for all of Europe, but I just know the training in France is different from the training in North America. I had a lot of my friends back in the university that wanted to go to Quebec, just because obviously for French language. They were saying that's really difficult because of the strong emphasis on clinical, as opposed to way more scientific background, and just years and years and years in university in France, where we would spend 5 years at the university with professors that were very interesting, but we were not really doing clinical up until the 5th year, where you finally go into the hospital and you meet with patients and pharmacists, and now you can do PK and PD and apply it to real life, as opposed to just going by the book. So we spent a lot of time, and the feedback that I got from my friends who went to Canada were that in Canada it was much more clinical emphasis, and so it was difficult for them, but that was on the 4th year, so they would go 1 year early compared to everybody else who would go to the hospital on year 5, and just a different way to train. And I know that for myself, I'm going to get my license in the United States. I've looked at how it all goes, and there's definitely way more clinical, which I think is good. Even yesterday we were talking with Alec about the fact that pharmacists get a course for injections. So I looked it up this morning. I was curious. I know that was recent in France, where pharmacists would inject their patients for a vaccine, and that's been optional and but recommended as of 2019. So it's pretty recent that finally you can get a script, bring it to your pharmacist, and get a shot for the flu or whatever. So those are different, and I guess in the United States it's probably more, and in Canada more advanced in that sense.
So what did you learn in pharmacy school? Can you kind of break it down?
Oh, you get a lot of physiology, you get a lot of organic chemistry, you get a lot of even some physics to get started for the first couple of years. And then you go, as years go by, you go more into immunology, cardiology, but this is very theoretical. So you just look at all the drugs that are being used, obviously, with the pharmacokinetics and pharmacodynamics standpoint. But it's just you go by the book, and that's just how it goes. Then you applied pharmacokinetics will be on the 5th year. So you just spend a lot of time looking at the epidemiology, looking at the physiology, some anatomy as well, not as much as the MDs obviously, but yeah, it is a lot of book reading, and that's the way it's trained in France. I don't know how it is in the UK and Germany. I mean, compared to every single country, obviously, but it's not as strong. I mean, again, it's what I've heard and it's what I've seen now, and I'm getting into the process of getting a license. It's just it's different, right? You don't have as much clinical. That's the big thing.
During your 5th year, did you routinely work in an interdisciplinary team, or specifically the pharmacy team? For example, did you round with the residency or medical students?
Twice a week, round with the residents and the head of the unit. So for me, that was infectiology. So we were working specifically with the pharmacist that was there as a resident. So me and her, we were working on specific antibacterial treatments. So, just looking at potential resistance to bacteria. and that was our thing. But then we would go to the round table. We wouldn't not really talk too much, but just kind of listen to what the doctors and the head of clinic were talking about. Go out and meet with the patients. There was that. I was doing this, and then I had another semester doing hematology. So I saw a lot of blood work, which is what I'm still doing now with Gillett Health. Saw a lot of blood work, and that was very interesting. So we had some more of a research side of things with just looking at different pathologies, but like applied in real life. And so it took 4 years to get there, because finally you can actually see real people with and then you get to meet the researchers, you get to meet the MDs, you get to meet the nurses. So you kind of step out of the pharmacy through a pharmacy training. There was a lot of biochemistry. There was a lot of that. So we don't go to college and get an undergrad and then go to pharm school. So you kind of get all of that together, and then finally get to go out and do more clinical stuff.
So where do you see, besides clinics, where do you see pharmacists working predominantly? Or what are some common non-traditional roles that you see your classmates or PharmD colleagues in?
There's been, obviously the big part would be just regular pharmacies, like in the United States that would be CVS, Walgreens. You get a lot going to medical affairs. Actually, you get a lot going to quality. You get a lot going to regulatory. You get a lot going to cosmetics. There's a big segue into cosmetics for a lot of us. So the industry part of it is quite important. And then you get, I would say, a minority going to the hospital and clinics. It's just an extra 4 years in France, so you become an intern, and it's quite tough. And I would say only the most motivated and the grade A plus students go into the clinical side of things, so a lot of respect for them. I went into marketing myself because I wanted to kind of segue into business. And so I got an extra year of training for marketing and strategy, which was quite a lot of pharmacists, engineers could actually get in there. So we had a big class of half pharmacists, half engineers, which was interesting. So we got training for medical devices, how to get on the market, but more from a marketing standpoint. So
I definitely see more pharmacists integrated into the clinic. That's one of the things that I missed about academia is the interdisciplinary team where they have the pharmacist right there and the PhDs as well. With the advent of precision medicine, so precision pharmacokinetics, genomics, you have a background in engineering as well. So you have worn a couple different hats.
Yes. Yeah, so my bachelor's was in biological systems engineering, and my PhD was in regenerative medicine and biomaterial design. So still got to wear the engineering hat, but also interface in a hospital setting, even in some patient-facing research roles. But everybody's PhD is extremely different. I really only know biomedical science and clinical PhD. So, all of my insight is really in the hospital and the research side of things. Obviously, you can get a PhD in just about anything, but there are a lot of similarities, I think, between PhDs and PharmDs in terms of what they go on to do. But our education, is significantly different, where a PhD student generally takes the GRE and matriculates in a certain program, whether it's immunology, in my case it was regenerative medicine, and you spend generally the first 2 years taking didactic classes, and occasionally these are with PA students, PT students, depending on the university, MD students. You see a huge variety of the types of students in your classes, which is really interesting. But generally, the first 2 years are didactic, and the education is structured more like in undergrad, where you have a variety of core classes. For us, it was macromolecules, physiology, anatomy, medical immunology, cell signaling, and really in the second year is where you start to become more specialized in your education, right? So the saying in around PhDs is you get really, really good. You learn everything about one tiny little subject. And part of that, I think, is by choice. When I was getting my PhD, I didn't want to do that, so I sought extracurriculars in the clinic, and really branched out from a basic research lab, so a basic science research lab, and started, working on the clinical side of things. But so you don't have to fall into that trap if you get a PhD. But that being said, you also, the most significant part of getting a PhD is carrying out primary research. So generally, PhD students have to publish at least one first author publication, but generally the requirements are more than that. So this is, carrying out laboratory or clinical research and publishing it in a peer-reviewed journal, which is no easy task and takes a long time. And generally, at least for PhDs, most of them stay in academia. So the logical, or I guess the general process after graduation is joining a postdoc, which, the equivalent for an MD would be a residency. And, a postdoc generally is anywhere from 2 to 5 years, with the hopes that you become a professor. And I would say that the rest of these PhDs go into industry. And really, this is where the similarities are with the PharmDs. They go into medical affairs as medical science liaisons or medical information specialists. At least in my experience, our medical information team is made up of pharmacists and PhDs. Medical affairs teams generally are made up of PharmDs, PhDs, and MDs or DOs. And you see them, a lot in R&D as well. So there are a lot of opportunities, I think, outside of academia, and generally, my assumption was as I left academia, I would be collaborating significantly less, but that has been the complete opposite. I found, that my day-to-day is consistent engagements with physicians, nurses, nurse practitioners, PAs, PharmDs. So it's interesting to see where my classmates, have kind of ended up. But all of them have stayed in medical research except the select few that are in venture capitalism, or I guess haven't stayed in research but stayed in medicine.
What would be your advice to clinicians? During training, a lot of clinicians, especially medical doctors, worked on a few studies and they have interest in it. But a lot of these individuals are no longer in academia and they're no longer associated with industry. So they're at clinics, hospital-associated clinics, private clinics. How can they get tied in to help regenerate that?
Great question. There are a few ways. The first one that I would tell to that type of provider, and I would also tell to a PhD student, is there are no rules on what you can and can't investigate as long as you're doing it legally, obviously. And you can publish that on your own. If it's something that you're passionate about, like I know that you and I have published in the past, and are will be publishing again soon. And this was an unfunded study outside the scope of my previous research, and really outside of the scope of your practice. But it was something that we were passionate about, so we generated meaningful data. And there are no, there may be limitations, whether or not the author has to have a terminal degree or some some type of medical degree, but you can just try. The other approach is to make a connection with industry, and this is a really important collaboration, and this, I think, drives some of the most meaningful research that's going on, where a provider may know their sales rep or may have an idea for a certain drug or device. They should be put in contact with their medical science liaison. And this is where investigator-initiated trials really come to life. So let's say that as a physician, you've got an idea, maybe it's an off-label application of a drug, or it is a novel observation you've made in practice. I'm seeing this outcome that I see is void in the literature. You would liaise with a medical science liaison, so another MD, PharmD, or PhD, and develop that idea together. And that is a very viable and rather streamlined way to begin clinical research. And I think it's also interesting to see young physicians go that route and really start to establish themselves in their therapeutic area. And the long-term downstream ramifications of that are building, industry relationships, and generally that leads to speaking or presenting at conferences or congresses, which in turn drives more collaborations, and that may look like clinical trials, pipeline studies. So that really, it's interesting to, in my line of work, to start to work with MDs that have never done any research but have great ideas, and all of a sudden you see them take a very research heavy role with their industry collaborators.
Something I've seen last year when we were at the A4M, you would have researchers look at, I believe from their personal experience, looking at uric acid and metabolic syndrome. And something that then prompted me to do more research on uric acid, because I thought that's just, allopurinol, gout, whatever. It's just uric acid. You don't really pay too much attention to it. It's just a small, cheap marker. And now I kind of want to look at it in pretty much everyone because of the association between uric acid and metabolic syndrome. And that's because of, obviously someone else going out and observing from their practice as an MD. There was the one presentation about it, and I thought that was very interesting because that's just what they see, and then there's a theory, there's a hypothesis, and then they go on, and eventually it becomes something that may be impactful, and it's something you have to be passionate about, and as long as you kind of go and observe it, and if it's meaningful, you want to publish. I think it's there's nothing wrong with it.
It's a good example of if you notice something anecdotally in your practice, it's great if you share that with the community, especially people with a similar patient population, but it should be presented as that. So it's not like you're presenting, for example, uric acid, don't check a fasting insulin, don't do a CGM, don't check an A1C, just check uric acid. Obviously that's not the case.
Right.
So it's good to present it as, this is something I've noticed. We don't know the significance of this, but it is a useful tool and I've used it. And we certainly share our findings publicly and also amongst ourselves as almost like it reminds me of an academic center when we have people, essentially an interdisciplinary team at Gillett Health, and we share findings amongst each other and use that to apply different topics clinically. A lot of individuals who listen to our podcast or who are interested in our individualized medicine project have lots of different degrees. There's PTs, DCs, NDs, a whole host of different degrees, PAs and NPs, of course, MDs and DOs. And a lot of them are also practicing functional medicine providers. And often we get the question, how do we know what to try to see and what to try to refer on? And it can be a very difficult question to answer, but just keep in mind there's been many different studies, even with MDs and DOs, and MDs and DOs provide a higher quality of care if they're part of an interdisciplinary team. So what I encourage other healthcare providers to do, including MDs and DOs, but especially so if you're applying new scientific topics and you may not have that same degree of background in your training, it's even more important to work with an interdisciplinary team, just so that that Swiss cheese is as thick as possible, and ideally at the end of it you would have an MD or a DO as the rind.
I think that's a great way to look at it. The more eyes you have crawling the clinical literature or observing what's going on anecdotally with patients and in the lab work and from a pharmacology standpoint, the more successful and the stronger that team is going to be. 4 brains is always going to be better than 1. And I like what you said about always being plugged in with an interdisciplinary team. Because as a nurse practitioner, I kind of get caught up in this where, there's a huge push for independent practice, and I'm not sure that it's fully warranted. I don't have an issue being plugged in with the team. I don't want to be on my own island over here treating patients independently. I like to be plugged in and always have someone that I can go to and say, hey, have you seen this before? Or, hey, what do you think about, this theory? Because I'm always, tinkering. I'm not necessarily thinking, okay, I'm going to treat hypertension, diabetes, lipids, and then anything else I'll refer. There's some people, primary care providers, that they treat the common pathology and then they refer out, and that's an important service. A lot of times primary care does get a bad rap because, they don't know exactly what's going on, but there's just so much pathology now, we know so much more, that you have to have specialists that you can refer out to, and knowing when to refer and when not to refer is very important. So I think whenever people who have vastly less medical education and less clinical experience, for example, a new MD that's completed residency versus a new NP that's completed clinical hours. Some states that's around 600 hours, and then they can be independent. The university that I went to was, I believe, 750 hours of clinicals, and I actually participated in some extra clinical hours because I had really good rapport with my internal medicine physician that was my preceptor at the time. He had been in practice for 30 years, seen lots of great things, so I was always writing things down and stashing away these clinical pearls that would come about whenever we were going and seeing the patients, and taking a very autonomous role but also having backup at the same time. And I have heard some more unfortunate cases where the NPs are essentially shadowing during their clinical hours. They're not doing the differential or the critical thinking, and then a lot of times they get into practice, they're overwhelmed, they think it's not for them, so then they'll go back and end up working as an RN, still having the NP degree, but just it wasn't for them, and it's not for everybody. So it's important to realize it is a very autonomous role if you want to pursue that and complete it. But even though you're functioning autonomously, you want to be plugged in with other medical professionals, just like any healthcare team should be.
So what did your education look like? Can you kind of talk about your route to being an NP and how those classes differed from what Ben and I spoke about, and sort of where you're at now? Another question would be, how does an NP differ from a DNP, from a CRNA, and from an MSN?
Yeah, I went right out of high school into nursing school. Usually there's about a year of the biologies and the chemistries and certain levels of math and communications classes, your prerequisites you would take. I was in a fortunate place where my mother advised me and was working for a local community college where I was able to get those done early, do those in high school, and then the summer after high school, and then go right into LPN program. So I had my LPN license at age 19 and started working part-time on the weekends as a nurse while completing my associate degree of nursing, which is what most of your RNs are, unless they attend a 4-year program where they're getting a BSN degree, which is a Bachelor's of Science in Nursing. So I got out and started working as a registered nurse, and within a year I moved to that float pool position that I referenced earlier because I didn't want to do the same thing over and over again. I liked the variety. It helped me to stay engaged and continue learning. And then the path for me to a master's degree, which is what I currently have, involved first getting the bachelor's degree. So that was a lot of theory, a little bit of statistics, epidemiology, informatics, so looking at how clinical decision-making tools are created, things like that. And then at that point, once you have that BSN, there's, I believe, 4 or 5 branches you can go into. There's a family nurse practitioner, you have a acute care nurse practitioner, and the family nurse practitioner, which is what I am, functions outside of the inpatient model, so they're working at your urgent cares, your family medicine practices. Acute care is really limited in their scope. They could probably function in an urgent care, but they are only trained to see adult patients, and typically those are going to be the ones that are in the hospital working alongside the hospitalists. You have the nurse educators, which are people that want to go back and pursue teaching, becoming a professor or assistant professor. You have nurse midwives. And then I believe there's even a terminal, like a master's degree in informatics, for people that really just want to look at the numbers and develop new tools around that. So that's the general branch decision-making point. And for myself, the F&P offered the most variety. So if you're an F&P, you can always go back and do acute care. You can always go back and do I believe it's like a 1-year emergency medicine course, clinical fellowship. I don't think it's appropriate necessarily to call it a fellowship, although some places are starting to do that. The fellowship is typically much more involved if you're looking at the time difference. So I said, well, this has a lot of variety, so I'll do this. And I did have the intention to primarily treat adult patients, because the process of going through a differential on an adult patient is very rational, whereas a lot of times in children there's a strong psychosomatic component to the pathology, which I find to be a bit puzzling and confusing. I'm more in the rational box when I like to problem solve. So I had the intention to primarily treat adult patients, and the coursework is about a 30-month process, 2.5 years after the bachelor's degree. So there are some programs that are faster or slower. It really depends on the time you want to set aside and do that. Usually people will either quit working to pursue the program, or at least cut back on their hours and work part-time, which is what I did. I worked typically a shift or 2 per week while I was doing my MSN program, because I really wanted to dive in. I didn't want to just coast through, because the programs have good content, but you get out of it what you put into it. So lots of paper writing, lots of case studies, lots of developing the treatment plans. And this is before you are actually treating patients in person. So I would say that's similar to your medical school when you're looking at the courses like your A&P, advanced A&P, pharmacology, advanced pharmacology, looking at medical statistics and epidemiology and all these sorts of things. And you go back through it, it's less of a speed run than it was in the ADN program. The Associate Degree of Nursing program, you're essentially 8 weeks, here you go, this is this body system, this is this body system, and you just speed run through psychology, cardiology, your respiratory system, just very quickly. You go through most of the common disease processes. Now, you don't necessarily go through every condition that you're gonna ever see, or that you could ever potentially see, but you know your red flag signs, when to refer, how to treat common things, and then you go into the clinical environment and you start putting all the pieces together. So, in my opinion, I think that should be done under a MD or DO. Some programs in some states will allow you to do your clinicals under an NP, and I think that the quality is going to be more variable from NP to NP than from a MD to an MD. Because medical school and the residency, from what I understand, is very intense and demanding. So you're selecting for the most intelligent people to get in, and then also the most resilient people to follow through and complete that 4 years of medical school and the residency. So that's kind of how they compare in my mind, just a very simple way. But as far as the actual getting to where I am now, I think that having a great internal medicine MD was a great tool for me. I've kind of taken a bit of every practice that I've been in, all the best parts there, all the best tips, tricks, all the best clinical findings, for example, physical exam tricks, things like that, and incorporated that into the practice that I have now, and I continue to do so. Every time I meet a new interesting clinician or clinician that says something that I'm not familiar with, I always want to pick their brain a little bit and then see, okay, is this something that is evidence-based? I think the functional medicine world is a great point of this. Some people will say, if you hold something close to you and you feel good, that's a positive aura, it's far away. I don't want to discourage anybody's beliefs, but for me, that's not something that I incorporate into my practice. I'm more, like I said, very hyper-rational and data-driven. And what I believe I practice is like evidence-based integrated medicine. So you take your patient, and the first thing you want to do is true preventive medicine. You go down your checklist. What do you want to prevent from happening? And then your patients, you say, okay, what are your specific goals? How do you what are your areas for improvement? Do you feel like you want more energy? Do you want to lose weight? Those are probably the two biggest things that I hear people talk about. And then you build an individualized plan to get there. For some people, they don't want to take medications, and that's fine. You can use supplementation. Targeted supplementation is very important. I don't have a take these 10 supplements stack for every individual patient, but you take it a very nuanced way and say, okay, if we're trying to increase, dopamine signaling is a very popular topic, something that people are commonly asking us. They'll say, okay, well, we can do this. But that's kind of how I think of it, is the smart prescribing, smart supplementation, and then pursuing what a individual wants to pursue. We have the flexibility to do that with our individualized medicine program.
That's one other question we get about the individualized medicine program often, is they say, well, I want to sign up, but tell me more about working with Gillett or more about working with James. And part of signing up for the individualized medicine program, as we've talked about, there's lots of differences in the education of an MD and an NP. But what you're getting specifically with our team is we talk together all the time, pretty much every day, and you're getting that question. So, and if we have a question, a lot of times we'll ask Ben as well. So you're getting a whole team of people that work together, but you're getting it from a different perspective. So there is a difference, and depending on what your goals may be, you might want to sign up for like one option versus another. But regardless of the option that you're getting the whole team anyway.
Yeah, I think that's a great way to phrase it. And to kind of circle back to something you mentioned, the DNP, so I guess the furthest terminal degree in the science of nursing. Based on the courses that I've seen looking at these different programs in the universities, it appears to be largely a nursing theory degree as opposed to a clinical practice degree. So it's more so looking at a organizational system or an academic role as opposed to, the doctorate degree where you are a medical doctor. So I think in the academic setting, if you are a professor, it's appropriate to introduce yourself as Dr. So-and-so. But if you are a DNP in a clinic or a DNP in a hospital, I think it's a bit misleading and perhaps confusing for patients to introduce yourself as Dr. So-and-so, because there's lots of doctorate degrees, but if you are a lawyer, for example, you don't go into a hospital and introduce yourself as Dr. So-and-so. People are going to be very confused.
There's definitely been some instances of confusion when a patient introduces themselves as, I'm Dr. So-and-so. I walk in and they say, I'm Dr. Gillett or Dr. Kyle, and then they say, I'm Dr. So-and-so, and then, they're a doctor of something didactic. They're a doctorate of, let's say
mathematics professor.
Ethics or mathematics, which is great, but it's just confusing because when they say that, it kind of turns on my brain to where you're trying to meet the patient at their level, and you almost just assume that they're a medical doctor, and it's just not good for communication, and sometimes it takes a minute to figure that out.
Yeah, and that's a setting where it's on the patient side, a context where the patient says something and it could be potentially, confusing for the provider and the patient both. Now imagine the setting where you are the patient and you go into a center where you expect to see a medical doctor and someone introduces themselves as a doctor. You're going to just assume that person is a medical doctor.
Yeah, that would be quite disconcerting if I was a patient and someone introduced them as a doctor. I would feel like it was false advertising unless they were an MD or a DO.
I do get patients asking about Dr. James. So obviously I kind of make it clear who they're going to work with. And obviously never going to say anything negative about James, right? But I'm just saying MD and B, obviously you can say Dr. James all you want, but there are differences here. And we don't really spend too much time explaining the whole background, but it's great to have a discussion today. So, hopefully people understand that it's different backgrounds with the same goal in mind at the end of the day, but coming from different perspectives, which is super interesting. Like I really love having this chat.
Yeah, that's a great way. Different backgrounds, but the same goal in mind. And I think that's true of any healthcare profession. Like at the end of the day, people are trying to help their patients, but to talk about the differences, and this could be useful for people listening, I talked about my clinical rotations, which could be anywhere from 600 hours to 1,000 hours, depending on the program that you're looking at. Compared to a residency, just kind of talk a bit about what the hours that you're committing during a residency are, like how much more time with patients and pathology exposure you're getting in a residency, for example.
It's not unusual to have an 80-hour work week during residency. In fact, before they implemented these new laws and they limited residents to 80 hours a week, and you actually have to time track this and submit it to the ACGME, which is the accrediting body for graduate medical education. And often it actually ends up limiting your moonlighting opportunities more than anything else. But it is not unusual to have 80-hour work weeks, lots of night shifts, and in general, residencies are at least 3 years. So, and that's after a medical school that is usually 4 years long.
Right, so if I'm looking at the, say, total time, the number of courses spent on strictly the nuts and bolts, the meat and potatoes, the pathology that I'm looking at, it's probably 2 years of the coursework from both the associate degree nursing program and the master's degree program are going to be actual clinical practice, because there are courses in the informatics and nursing theory that are sprinkled in there, and compared to that, it's probably 50% of the 4-year medical school. But then the clinical hours or the residency hours is a much more vast difference. You're looking at 600 versus 6,000 to 12,000 hours of postgraduate experience where you are putting all the pieces together.
And a lot of that experience is supervising other residents as well. So you learn a lot by watching. Often before medical school, you even shadow physicians, and you do learn from shadowing. And then you learn a lot by having preceptors or attending physicians. And you will hopefully be doing it won't be shadowing, but you'll be doing it under supervision. And then as you become a senior resident, and there's interns that you're supervising and other junior residents that you're supervising, you're doing a lot of that supervision yourself. And that is also extremely helpful. And not only are you supervising, you're also being supervised at the same time. So again, there's multiple stops and there's multiple people looking out. So it's not only, let's say you're an intern, you have a senior resident supervising you, sometimes a chief resident supervising you, an attending supervising you, the pharmacy team supervising you as well. So there's a lot of different people that are looking out for you, and you pick up those same things intuitively. You say when you start medical school, you have an incompetence. You're not competent yet, not because you're completely incompetent as a person, but it's just called unconscious incompetence. And then you slowly develop the realization that, so you're conscious of it. So Then, as you get later in medical school, you're conscious of your incompetence as a healthcare provider. And then through residency, you have what we call conscious competence, and this often develops during the intern year. That's when a few months after your residency, you finally have the feeling, I can actually do this, I am competent, and I know why I'm competent. And then after residency, especially after years of practice, often you develop an unconscious competence. You're still competent as a healthcare provider, and you're still making many of the same decisions and following the same patterns, but you're not as conscious of why that is. So you know, another way to say it is you know more what to do, but you are not as sure why. And ideally, as a lifelong learner, you continue to know what to do and concurrently know why that is as well.
That was an exercise that I used personally in my clinical rotations, right? After, let's say the first week of clinicals, I would say, okay, this patient has this, so we're going to do this. And the preceptor would say, okay, now why? And then I was like, well, because that's what we do for that. So then I would have to go back and he'd be like, come talk to me tomorrow and explain your reasoning for like this. So it's like a little bit of a homework assignment, but then after a while I was doing that intuitively and often explaining it to patients as well, in more or less detail depending on what level the person wants to be spoken to on. So it's something that I always ask myself, if an intervention is being applied, then I want to make sure that I understand it myself, I can explain the underlying mechanism, and then I can also explain that to a patient on a level they can understand.
Yeah, the Socratic method, or lots of questions for people learning to be healthcare practitioners, is particularly helpful because, like you said, you know the why, and you also are able to explain it back to the patient. That allows you to make a shared decision making. I guess that's a good segue into your perspective on things like this. From a medical affairs standpoint, you're in a lot of different settings and in a lot of different states. What do you see as the different cultural shift or perhaps regional shifts regarding different degrees and how they are referred to or accepted in the clinical area?
Good question. There's a lot of variability state to state in terms of what's different degree or how different degrees practice. I think the best approach, at least from a medical affairs perspective, is give everybody the same baseline of education when they're learning a new therapeutic area or how to use a new drug. Don't ever assume, just because for example, this person is a dermatologist or a dermatopathologist and have 15 years of experience, that they're going to know more than, let's say, somebody who is an RN with 5 years of experience. They may know the same amount. So, it's from the industry and medical affairs perspective, continued education is paramount. And it was interesting listening to you describe your change in self perspective. So you're unconsciously incompetent, but it reminded me of the Dunning-Kruger effect. Which is
Thought of that too.
Yeah, you start to know a little bit, but you think you know a lot until you learn more and realize you don't know anything.
Yes.
So I think, that's, as a provider too, the ones that I see hungriest for knowledge tend to be the ones that are the most experienced and the most specialized. And in conversation and in collaboration, they're always the first to admit when they don't know something. And it's a really interesting thought experiment, and generally they perform the best in research as well, because they are consistently asking questions.
Yeah.
And this makes, as a provider, this makes you extremely valuable as well. And what I mean by that is, if you believe that you know all there is to know, you probably aren't asking very many questions. So that makes you, generally a poor collaborator. You probably don't have interest in research, so it's, and really your interactions are limited purely just to CMEs and more education. And it's, there's much to gain from being open to learning more and doing research as a provider, especially a young one that is really just starting and getting their footing in a certain therapeutic area.
There seems to be a great filter of extinction when it comes to the curiosity, the wanting to ask the questions, and that great extinction seems to be upon reaching a terminal degree, whether it's an MD or PhD or a PharmD. We've seen a lot of our colleagues get that degree and be extremely curious. They want to dive in. They want to, publish new knowledge. And then after getting that degree, it's just kind of assumed that they know everything that they need to know, and then they no longer need to look anything up. I've even had people tell me, that I don't know what I think about your practice style. You look things up so frequently. And it's just baffling that that would be perceived as a negative thing.
Right. It's I've seen that as well, and was absolutely mind blown by a patient feeling uncomfortable with their provider gaining more knowledge to treat them. It's that's what you should not only want but expect. It should never be discouraged. Additional investigation should never be discouraged. And so that's, I guess, as in my current role in medical affairs, that's really, it's the favorite part of my job is when somebody's asking questions, right? And it's, and they're basically, tapping into industry to give themselves an interdisciplinary team to build a study out of. And it's, it's super fascinating. If you look at global KOLs, key opinion leaders, what are they most likely to do? Collaborate, research, ask the important questions, and share their findings, on a big platform.
Yeah.
And, you look no further than the colleagues that you've sat down and had conversations with. Dr. Huberman, for example, is a great one at disseminating novel insights that he's gained.
Yeah.
And particularly outside the scope of what his PhD and primary research has been. And it's a super important learning lesson. And there are other ways to take this, which is, as a provider, if you want to get involved in industry, there are many routes to do that, and there are a lot of different advantages as to why somebody might want to do that. And in industry, you're certainly not limited to collaborating or researching with physicians. For example, it is not uncommon at all to have a key opinion leader who is a nurse practitioner or a PA, and they also lead CMEs. They publish studies, they have projects funded, they lead, cadaver courses, and they fill the exact same role that an MD or DO would fill. Is it less common? Certainly, and I think that goes back to the different types of education where, James, you tend to think a lot more like a PhD in terms of looking at the literature and really having a deep understanding of why you're doing what you're doing, and that's so I think there are less NPs and PAs that take those KOL roles, but the ones that ask those questions are phenomenal KOLs, and they're great clinical collaborators to have in industry. And I see generally it really elevates their practice as well.
Yeah, that's interesting. You can think of that as selection process, whether it's an MD or a mid-level provider that's going to be the KOL, they're essentially very motivated to look into something. They're passionate about it. It's personally interesting to them, so they want to pursue that to the highest level, and then be able to, just like you talked about, things that you find valuable in your practice, you do feel inclined to share those with other people, because at the end of the day, we're all trying to help our patients feel better, look better, live longer, just whatever their individual goal is. The goal at the end of the day is to help the patients.
When you're looking for a specific goal of a patient, that also helps the empathetic approach. So the empathy, really feeling what they feel in their shoes. Again, going back to medical education, if you look at empathy, it's generally very, very high in individuals who start medical school, and then it just slowly or slightly more precipitously drops off as education progresses. And there's a lot of different reasons for this, and perhaps some of it is inevitable, but maintaining the view of seeing things from the patient's perspective is going to help maintain a higher level of empathy.
Yeah, I can think of some case studies of this, and this is not just limited to probably medical doctors, but also nurses and mid-levels and lots of different professions across, not even healthcare. But there are some case studies where you'll have a patient who is in a diabetic coma, but if they're just dropped off in the ER in a busy city hospital, you would just, a lot of times the staff will, or I shouldn't say a lot of time, but there have been cases where the staff assumes that they are just severely intoxicated and they're going to sleep it off. So it's always important to not frame a case in your mind based on your personal biases, to kind of approach each case with a open mind. You don't want to have this is the treatment that I'm going to have in mind, because if you go in with an open mind, something the patient says may prompt you to dive a little bit deeper. Whereas if you've already made up your mind about something, you've essentially eliminated the rest of the differential subconsciously.
Something that gets asked a lot whenever patients come to me and have a first contact when it comes to Gillett Health, and they ask if it's a cookie cutter protocol. And obviously the answer is never yes. I mean, we would never go for a cookie cutter protocol. Those are your symptoms, and this is what we do. And we don't really question why we do it. So that's the importance of individualized medicine, where everyone is obviously different. And if they have the same symptoms, it doesn't matter if they have the same symptoms as someone else, and we don't put them in the same protocol, because we want to understand why they have those symptoms in the first place. What's their background, what's their lifestyle, all those kind of holistic approaches to this. And then you kind of end up with potentially the same protocol, but it's not because we are cookie cutter. It just so happens that obviously sometimes people have similarities, and so they get similar protocols, but it's never cookie cutter.
Yeah. Patients will say, oh, well, what is the plan going to be? What is my treatment plan going to be? So I know before I get started. And I don't think that they're necessarily like you wanting to seek out a certain treatment plan. They just want the information. Mm-hmm. And you can't decide that until you've done a full evaluation, full medication reconciliation, looking at the family history, because even though they may have, a goal of just say X, like I want to lose weight, like what are you going to do for that? It's like, well, we have to figure out what has worked well for you in the past. What have you struggled with in the past? Where is your weight on the timeline of your life? Is this your all-time high, or were you 50 pounds heavier a few years ago? There's so many individual differences that you want to parse out and take into account. Things like family history. It's like, oh, well, your goal is to lose weight, but you have a strong family history of heart disease. We should probably see what's going on there, what genetic risk factors you have, what things are modifiable.
Compare that to a clinic, and every clinic model has potential viability. Think of it like a restaurant model. Some restaurants, you just go there and you can't even order, you just get the same thing. They only have one thing on the menu. If you don't need that thing on the menu, you probably shouldn't eat at that restaurant. Gillett Health would be more like a private chef, where we create the exact protocol that person would have the most benefit from. Whereas some clinics, specifically weight loss clinics, the price of your medication is included in your monthly fee. So your monthly fee is your GLP-1 receptor agonist, like semaglutide as an example, and then plus any visits that you might need over the course of 1 year. So that's never going to be as high of a quality of a program, even if they screen for things like risk of pancreatitis or hypertriglyceridemia or risk of cholecystitis or cholestasis or like essentially risk of a gallbladder attack. Even if they screen for those things and other contraindications too, of course, then even if you're a mildly good candidate, there might be something better or something that will have another therapeutic benefit in addition to that. It's just not going to be as high quality of a clinic. And then you're looking at other red flags as well. Will they send that to any pharmacy? Probably not. Will they order labs outside of their system? Probably not. Will they recommend supplements outside of their system? Again, probably not. So you're just thinking about, a cookie cutter program in general is bad, but if there is a protocol and you happen to fall into that group, it doesn't necessarily mean that no patient should get that protocol.
Yeah, I like what you're saying about, there's so many variables, and this probably crosses over into any industry. Like, for example, in the regenerative medicine realm, does everybody get the same thing? Does it work the same for everybody? I would presume no. There's got to be some nuance there. So could you speak a little bit about how you have to kind of frame the minds or help to shift the mindset of the providers you work with on a daily basis to say, hey, this may be what you're using 75% of the time, but you're looking at X, Y, Z, kind of what the framework of the process you go through to talk to people about that.
Yeah, it's actually a big issue. When the thought process from the provider is provide me with a protocol. I want to know how much to use and at what, for example, how much drug I should use and at what dilution. Just tell me the protocol per the anatomy. And in my case, working in dermatology, how old is your patient? What's their epidermal thickness? And getting them specifically in the context of tissue regeneration, it is a lot more nuanced than just a certain dilution and a certain volume in a certain anatomy. And so that's where you have to understand, really at a deep level, what are you doing? And sure, this expert consensus says X. And generally, 80% of the time, that might be adequate. But you have to know what to look for, and you have to understand, in regenerative medicine, you really have to, I think, put on the engineering hats and look at things from a mechanical and a morphological perspective as well, right? So what tissue type are you emulating, or what type of de novo tissue regeneration are you driving? And so it is a difficult conversation, and regenerative medicine as a whole really is new. And so, by default, it has to be personalized, and when you start talking tissue engineering and in wound repair, where you are using autologous PRP, for example, right? By nature, by default, that already is individualized, but it's just your approach has to be so dramatically different and patient specific that it really is an entire paradigm shift in the way that people are practicing. It's exciting to see because I think the outcomes generally are better and more personalized, at least in the context of aesthetic dermatology. But yeah, the people that are adapting early have been extremely innovative, and it's it's a good exercise, to push yourself through, which is, constantly thinking about the patient, not the protocol. This is a tool, not a treatment.
I think this is a good example of how some clinicians, they have personal experience of what worked for them. For example, one specific protocol or medication or one thing that made a huge difference. And that can make it even potentially harder, especially if that protocol, even if that protocol is not part of expert consensus. But either way, if you have personal experience, then you need to avoid having that as a confounding variable or perhaps a fallacy, and you're trying to apply that same diet or medication or supplement that really helped you to all of your patients.
Yeah, agreed.
Yeah, that's the first place my mind went when you were starting to talk about applying one thing. Typically, it's going to be, in the context of weight loss. Oh, this diet worked for me. I've seen this diet work for some people. This diet is the best diet.
Yeah.
And the truth is, there's many different diets and many different medications that can affect weight loss, and we think in terms of averages.
Mm-hmm.
So, on average, a GLP-1 agonist is going to be the best weight loss medication. In general, metformin doesn't tend to cause substantial weight loss, but there are some patients, and we've both seen cases of this, where somebody starts on metformin and then a year later they're 30, 40 pounds lighter. And is the medication a catalyst for the healthy lifestyle, or are they just a really good responder to that medication? It makes the case even further for individualizing treatments and not just ruling something out because it probably won't work, although you do want to be realistic with the outcomes. I don't think that even these clinics that do promote GLP-1 agonists and they guarantee weight loss, if you look at the studies, there are people who will gain weight on GLP-1s. It's not 100% and nothing's 100%.
There's another interesting point too that I want to bring up is anecdotal evidence, and don't, as a provider and specifically as a researcher, don't fall into the anecdotal evidence is meaningless category. And if you're a patient, be skeptical of those providers because, at one point, every observation was anecdotal until it was peer-reviewed, published, and then in a review article, and then made its way into an expert consensus. So I think there still is value to gain from anecdotal reports, and obviously, they need to be taken with an extra grain of salt, but that's where a lot of inspiration and study concepts come from. So it's, as a provider, maybe pay mind, even a little bit, and same as as a patient, there could be useful information there, but also keep in mind that it is anecdotal. So walk the line of giving it a look, but not taking it for an absolute truth.
Yeah, and I think when you get into anecdotal things, people will make multiple changes at the same time and attribute it to a single thing, or they will start a single thing and then subconsciously make those changes. So essentially they are placeboing themselves into health, which is a positive thing, but I think that the placebo effect in particular is just such an interesting topic, because if you look at how strong the placebo effect can be in trials for treating depression, you have a couple of moving parts there. Your efficacy of a placebo could be as high as 60 or 70%. So you're looking at a condition that is self-limiting in many cases, so it's not going to persist forever. And then you have say a pharmaceutical company in a case that has to show a strong effect size in a short amount of time. So typically they're going to develop a therapeutic dose that is on the more aggressive end of the dosing range, because they want to develop that meaningful effect. So the level of nuance there is, okay, we have more than 8 weeks to build towards your health, and we want to minimize side effects. So we can start with a much lower dose. But there's all kinds of interesting placebo effects. You look at studies for testosterone boosters, and you'll see a 20% increase in testosterone from a a sugar pill essentially. A person believes that they're taking a test booster, or believes that they're taking a anabolic steroid. In some of the really old research, I think from the 1970s even, they get stronger and they feel better, and it's placebo. So you can certainly harness that if you are somebody who is starting an intervention and you really believe in it. If it's neutral at worst, it's likely to work well for you. You say, well, I'm going to go on the Mediterranean diet, which has good evidence, and I'm going to lose weight and be healthy on this. That's a neutral at worst intervention. It's probably going to be a good diet for many, many people.
Yeah.
So you can use that, believe in it, stay committed to it, and then improve your health.
A lot of the last few years with selective androgen receptor modulator research and use has been a really interesting sort of thing to watch unfold. Same with botulinum toxin literature, where you see really not a ton of primary studies, but you see some survey data, and the survey data seems to tell a completely different story than some of the research, right? So one of the SARM studies that we talked about yesterday was the survey study that showed an overwhelming majority of respondents said that their SARM use was worth it, and this polled a significant number of anecdotal SARM users, despite the fact that there is no compelling literature on selective androgen receptor modulator use in humans for performance enhancement. It's a very interesting, basically throwing enough anecdotal reports together for a publishable survey study. It probably, that may be actually a good way to approach analyzing anecdotal data, but always interesting to see where they diverge from basic science research and survey data.
Yeah, particularly in the context of when you've had some third-party analyses on some of these things, they find that there is none of the actual ingredient in there. And if a majority of people are responding well, or it would appear a majority of people think that they're responding well, they're getting typically a cosmetic benefit or a performance benefit that they're seeking. But then there's also a significant incidence of side effects, and you can even have side effects that are placebo.
Nocebo.
Nocebo effect, exactly. People with atopic diseases like asthma, allergies tend to be particularly sensitive to this. And Ben and I were talking about a study the other day in users of medications and then how it's framed in terms of side effects for the patient.
Now, I would want to pull up the exact study because I'm probably going to butcher it and give wrong numbers, so sorry about the inaccuracy here. But you can have 3 groups, and then the first group you just tell them, hey, this is a pill for your blood pressure, and it's going to solve the problem. And you don't re-educate the patient more, which is it unethical or not? That's another discussion, but that's the first group. So you just give them that drug, and you don't tell them too much, just positive outcomes. It's going to help your blood pressure. Second group, you give them the pill, you give them the name of the pill. You say this is, for instance, propranolol, whatever. And then the third group, you give them a pill, again, whatever drug you choose, and you tell them, for instance, with finasteride, there's a 5 to 10% chance, or even lower actually, of erectile dysfunction. And, just caveat, just a side effect that is possible. You bet the first group is going to have the real percentage of side effects, which is going to be whatever, 5 to 10%. The second group, they will probably go on Google. They'll probably research a little bit. They are being told this is the drug I'm taking. I just want to make sure there's no side effects. They're going to have twice as many side effects. And then the third group, where you kind of educate them, so you're doing the right thing as a provider. You tell them pros and cons, but you do tell them the cons, and they will have 30 plus 40% side effects. The more educated the patient is, or roughly educated, just being aware, can increase the incidence of side effects. And that's where you have the nocebo effect, which is well investigated in literature. It's really interesting to look at the nocebo effect in some specific medications that we deal with. So finasteride is a big one. We have people that are terrified of taking finasteride. They don't want to have hair loss. And I mean, I was that guy. I mean, I was this guy who would be taking finasteride, and now I'm getting in my head about it. Whereas having experience dealing with patients, you see people that take finasteride and they'll feel really good, and I'm like, damn, is it all in my head? You know, is it a nocebo effect? Am I aware of? Do I know too much? That's something that may actually happen. So the nocebo effect is very interesting. And when I look at the discussions about SARMs and so the selective androgen receptor modulators, you have a lot of those are sourced on the internet. It's underground labs, and they do third-party testing. I'm kind of questioning what kind of third-party testing they do. They have qualitative testing. Okay, they may have their HPLC, whatever, they may have that nice spike, and they say it's 99% purity. Okay, but you advertise it at, I don't know, 25 milligrams per milliliter. How much do you actually get? It's 99% pure, but I would want to see quantitative testing be more standard. So when someone ships their raws to whatever chemist in Europe or something, you would want to know how much there is, not if it's the right product, because then next thing you know, you get your RAD 140, and you think you're taking 10 milligrams, but you're actually taking a half milligram or whatever, and you know, you feel good and all that stuff. You know, it's working, and you're hitting your PR at the gym, but that's placebo.
And we've seen this many times.
And not just limited to UGLs, but also in supplement industry, because it is unregulated. You could have an error, an actual case study that was reported. 200,000 IUs of vitamin D in a supplement that was not supposed to have that much. So, you know, the quantitative and qualitative analysis is a great way to look at how these things potentially should be self-regulated by the individuals, you know, for example, a supplement company.
Yeah, I believe Dr. Huberman and Dr. Andy Galpin talk about this quite often, is that you need to use reputable companies that do third-party testing, and hopefully the third-party testing starts to include both the qualitative and quantitative analyses in the future. Even the most reputable websites where SARMs are usually procured, we've seen patients get labs, and SARMs have a very characteristic lab profile. And there's just no way that patient was on a significant dose of SARM. Perhaps they were given something else, not RAD 140 or LGD or Austrian or whatnot. But you know, it's quite obvious that they were not on it. And they're like, yep, I've been taking it every day. Here's my bottle. They show us the bottle, and that they've been taking it. So in those instances, it just really makes you a healthy skeptic with anything in the supplement industry. There's always potential, even with pharmacies, for having low quality or for having less than ideal quality control. But hopefully that qualitative and quantitative third-party testing is implemented more across the board. I think that, again, just like supply and demand, the public can demand a higher quality of testing, and that will help in the future.
That's important as a company. You want to associate yourself with compounding pharmacies that take those extra steps and are very transparent with how they work. We've been interviewing, so to speak, a few pharmacies, and we want to know exactly what's going on, because we've seen too many times, even if it's just a bad batch, it's bad luck or whatever they say, but we see that even from a compounding pharmacy, sometimes you don't really get the testosterone output that you would expect. So that's something we see, and you would be thinking that something as basic as testosterone, cypionate, should be pretty standard, but it's not always the case, so you have to be careful.
If you have a pharmacy that's producing variable quality of product, when you're using that product as an intervention, you're going to have variable outcomes in the patient population. And what you want is, the same thing in and out over and over again, so you have that consistency. And where these pharmacies are sourcing their raw materials from, I believe there's been whispers of these are all going to have to be FDA approved facilities that are producing these raw materials to try and cut down on some of the variability in how things are, or how compounding pharmacies medication quality varies so much.
You would think that's already the case, but not always.
That's another good topic, is the good and bad side of regulation in healthcare, and also the good and bad side of large, not necessarily governing bodies, but just large entities. So whether it's big pharma or the FDA, there's a pro and a con of all of this regulation. Obviously, it costs money, but if it's targeted in the right spot, then it's a wonderful thing. There's obviously lobbies and such, and there's always going to, like, the larger an organization, the more waste there's going to be within an organization, whether it's a private organization or affiliated with the government. But you have to let successful companies succeed within the current laws and regulations. And then you have smaller companies. So just like you have smaller clinics, like our clinic is a very small clinic, you also have small pharmaceutical companies or medium-sized pharmaceutical companies. And just like a lot of smaller government entities, like your local entity, perhaps your mayor or your county commissioner, can make a huge difference in your community for the better, so can a lot of these smaller and big companies.
Yeah, if you have a smaller company with less moving parts, things can certainly move much faster. Example of this would be your state and local government compared to the federal government, because there's just so many more moving parts and so many rate limiting steps, so many hoops you have to jump through to get to, say, making a change. The same thing is going to be for a pharmaceutical company. And if let's say the FDA looks at a huge pharmaceutical company and says, well, these are the standards that they're holding themselves to, we want everybody to hold themselves to this standard, then you're going to be stifling science to some degree, because you could have a smaller company that has a great idea and would have potentially had a great product that could improve patient lives or surgery outcomes or any number of things, but they can be stifled by the financial barrier to pursuing that research. And perhaps, Alec, you could comment on this as far as the cost of research and how things have to be approved and reviewed. I know there's certain processes you go through, and maybe how that varies from, for example, in vitro or preclinical models, because I know there even are ethical standards for, like, rat research, for example, and then how those increase, of course, whenever you move onto human subjects and informed consent, things like that.
Yeah, it's a good question. I will start with research is extremely expensive, and it is significantly more expensive in an academic setting, and that largely is due to personnel. So everybody has to get paid, including receptionists, lab managers, grad students, postdocs, the people that are in environmental services and are cleaning the floor that you work on, the people that maintain the HVACs. So generally that increases. So an investigator generally in an academic institution will submit a grant to a grant funding body, whether it's the American Heart Association, the National or the NSF, National Science Foundation, NIH, National Institute of Health, DARPA, the DoD. It doesn't matter. There are a plethora of multi-billion-dollar funding institutions, but an investigator will spend a significant amount of time drafting a grant and submitting it to one of these institutions, and generally selection rates are very low, so it's very hard to secure a significant amount of funding. Funding obviously is tiered, so certain amounts are awarded at different rates. R01s, for example, are awarded at a significantly smaller rate than smaller R21s, which have, they supply less funding. So you have to tailor the ask based on the scope of the study. That being said, once funding is secured by an investigator, depending on where you're doing your research, your institution immediately takes a significant amount of that money just immediately right off the top. And that's often where people are, you're paying the institution to use their facilities. Obviously, we're using a lot of core facilities: electron microscopy, confocal, tissue histology, animal sciences, veterinary services. So it gets convoluted very quickly, and there are a lot of moving parts and hoops to jump through. In industry, however, it's the investigator, assuming they're external, would be asking a company for money, for funding, for an investigator-initiated trial, and this tends to happen at an extremely, a significantly faster rate, and that's often due to a simpler study design, but also just due to the fact that you have you have way less hoops to jump through. And the equation doesn't get muddied as much. In terms of regulatory bodies, every university has different institutions in place, but some of the most common that you would find are IACUC, which is the regulatory body for animal experiments, all the way from small rodent models all the way up to pigs. And then, of course, IRB boards, and that is a minimum at research institutions. Many research institutions have an additional board or organization overseeing their human research experiments. That's so these institutions exert a lot of power. They weigh in on the intervention, on the number of participants. So it's research is it's a big business. Obviously there's a lot of good that comes out of it, but certainly there is a lot of waste. There are questions being asked that don't serve to really benefit anyone, with hundreds of millions of dollars going towards them. And it's a hard sell often, to say, I want to spend this money for the sake of knowing. When you know that there is no net benefit, is it worth it? It depends who you ask. Certainly the researchers investigating that question would say yes, but I think it would be really interesting to see different professions weigh in on what gets funding.
Yeah, we were talking about interdisciplinary, where we can expand to the VCs and whoever is actually investing in your company. They certainly want to have some research being published that is a potential financial benefit, and they just want to know that this stuff is going to make them a lot of money. If you publish for the sake of publishing, you may go bankrupt. Like you may advance science, but
it's
that's important.
It was an interesting transition from academia to industry for me, because I found that in industry the publications have to matter. It has to mean something, right? So you will have in academia 10 years of research for elucidating, a metabolic pathway, for example. And then that thing, but that never, you've advanced that field by your publication, which could be significant, but, it just doesn't translate to a patient. In industry, I find that the fidelity of research is higher, and repeatability is significantly higher because it has to be. Their industry published studies really, I think, spend a lot less time asking why or asking how, and really just focused on output, right? So, we know it's changing this, and we want to quantify or optimize how this is happening. So it's another interesting thing when you're looking at publications. What journals are they published in, and who's publishing them,
And the disclosures as well.
and the conflicts of interest, and the disclosures. Not a very, very low number of publications are actually reproducible. And I think depending on the specialty, at least from academic institutions, it is as low as single-digit reproducibility.
Wow, that's quite striking. We'd known about the 2% figure with preclinical models, but in published findings, the ability for another institution to repeat those being not that much better, so somewhere in the range of 2 to maybe 10%. That's quite interesting, and that when we're looking at the longevity studies, which you and I are quite familiar with, the interventions testing program, I think that's probably the reason that they run the study at 3 separate institutions at the same time with different research groups, so that you can be very sure that those results are exactly what is happening, and not as a result of chance or coincidence, or that it's going to be reproducible. And when you look at some of the data on the longevity interventions, I heard someone speaking about this academic. I was on Twitter the other day. They were talking about short-lived control groups are a variable that most people that aren't intimately aware with the research in those specific species are not going to have the nuance to detect. It was certainly new to me. So if I'm looking at a line of nematodes, for example, I wouldn't know how long they live on average. I would see, the intervention group had a significant extension in lifespan, so 20% or something. But if the placebo group was short-lived for some reason, then that study really should be repeated, so that you have a normal lifespan of placebo, and that you're actually extending the maximum lifespan, as opposed to just showing a difference a single time between 2 groups.
Yeah, great point.